Okay, let's go over the ethics cases. So the first ethical issue is informed consent, refusal of informed consent, and are there exceptions to informed consent? So if you look at the history, a 22-year-old woman is brought to the emergency department by a friend because of a headache, stiff neck, and a fever of 101.0 Fahrenheit. An LP is performed, and the gram stain of the cerebrospinal fluid reveals gram-positive cocci in pairs. You prescribe immediate antibiotics. As the nurse is hanging the IV medication, the patient, who appears confused, screams that she won't have the medicine because the nurse is trying to poison her, and she tries to pull out the IV. So in these cases, what they've basically done is phrased it in the way of a question. So we're going to address all these ethics cases in the form of a question. And the questions are, what are the medical indications for treatment? Is this a life-threatening emergency? And what goals of medicine can be achieved in this case? So basically, let's go to see how this is done. Okay. Let's look at the preliminary questions. What are the medical indications for treatment? What does this person probably have? Go back to the case. She's 22. She's got a headache. She's got a stiff neck. And she's got a fever. When you have that little triad, what do you think of? Meningitis. They do an LP, and what do they find? Gram-positive cocci. So they're going to treat her with antibiotics. Do patients have the right to refuse treatment? Yes. And we assume that every patient is competent to refuse, unless it's clearly stated in the question that this person lacks the capacity to give this informed consent. If I were to stop here, if I were to stop there, you prescribe immediate antibiotics, and the patient says, I do not want treatment, what should you do at that point? Treat or don't treat? You do not treat because she has the ability to give informed consent, and she's saying she doesn't want it. I mean, for the purpose of the test, we don't really need to get into the nitty-gritty of why she doesn't want it. We're going to take it as very black and white. She has the capacity to make that decision. If we get further into the case, what do we find? That she's confused. And why is it that she doesn't want the medicine? Because she believes that the nurse is trying to poison her. So is this disorder affecting her ability to make a clear and rational, informed decision? Yes. So if we go back, is this a life-threatening emergency? Can you die from meningitis? Yes. What goals of medicine can be achieved in this case? What are the goals of medicine? To treat her or not treat her? The goals of medicine are to treat her. Now let's look at the ethical questions here. Does this patient have the capacity to make medical decisions for herself? Based on the case that you read, the fact that she believes that the medication, that the nurse, is trying to poison her, does she have the capacity? Based on the information given? No. Should her refusal of treatment be respected? Respected. Should her refusal be respected? No. Why? Because she doesn't have the capacity to make decisions for herself. So we go into, do these circumstances warrant an exception to the legal and ethical doctrine of informed consent or refusal? Let's review informed consent again, which I already did in the psych section. Purpose of the treatment, right? Risks of the treatment. Benefits of the treatment. Availability of other alternatives. That needs to be explained to every single patient. But do we need to get informed consent from every single patient that we see? No, that meets the exception criteria. There will be many situations where we do not need to get informed consent. And what are those situations? Number one situation is an emergency. If a patient gets brought in, they're about to die, Do we look around for someone to give us consent? Or what if the patient can't give us consent because they're unconscious and they're going to die? Do we wait for them to regain consciousness and we ask them consent? If we do that, what will happen to the patient? The patient will be dead, and they definitely will not be able to give us consent at that point. So when there's an emergency, we do not need consent. Another exception to the informed consent doctrine is competency. You must be competent in order to give informed consent. If you are not competent, then you cannot give informed consent. A child, for example. Do we get informed consent from a child? We do not. Why? Because the child cannot give us informed consent. So who do we get consent from if we're dealing with a child? With the parents, the guardian, whoever is speaking for that child. But there's an exception to that. And that's a child which is called an emancipated minor. What's an emancipated minor? It's someone between the ages of 13 and 18. And someone who has met one of two criterias. Number one, they are married, or number two, they live alone. And live alone means you pay for everything yourself. Remember college? If you go to college when you're 17, but mom and dad pay school, mom and dad pay the room, mom and dad pay your food, and mom and dad give you their credit card so you can spend as much money as you want on other things, if something happens to you, even though you live alone in the sense of the word, are you truly emancipated? No, because mom and dad still support you. So what they mean by living alone means that you support yourself, you fend for yourself, you are responsible for yourself. So if that's the case, then you are truly emancipated. So marriage will do it, and living alone will do it. And those are the only two things that will make you emancipated. Okay. If this patient lacks the capacity to decide for herself, who should make decisions on her behalf? What do you think? Who makes decisions for us? If you are married and you are unable to make decisions, who makes decisions for you? Your spouse. If you are a child, who makes decisions for you? Your parents. If you are an adult who has not been married, who makes decisions for you? Your parent or a friend? You are an adult. You're 19. You are not married. You have a boyfriend. You're in a situation where you need a decision to be made. Does your boyfriend make decision, or do your parents make decisions for you? Legally, who is responsible for you? Are you married? Is there any legal document saying, this is who I'm with, this is who does everything for me? What do you think? Do you listen to a boyfriend who you've met for 3 weeks? Do you listen to your boyfriend of 3 weeks, or do you listen to your parents of all of your life for legal decision making? Who do you listen to? The parents. Now let's say you are widowed and you've got children and you've got your parents still alive. Legally, who's got the hold on you? The children or the parents? The children make decisions for you, not the parents. Okay? So is that clear? And please don't ask about first cousin, second cousin, third cousin removed, because it's not going to be that bad. The issue is, if you're an adult, you make decisions. If you're married, your spouse makes decision. If you're an adult that's not married, your parents make a decision. If you're an adult who's widowed and have children, adult children, not a 5-year-old child, but an adult child, and parents, then who makes decisions? Then your children make the decision and not your parents. And that's the guidelines that you follow. Now, what if you're alone? You have nobody. You're one of these sad sacks. Nobody to make decisions for you. Boo-hoo. Then who makes decisions for you? Then the doctor makes decisions for you. Exactly. You're alone. You're a sad little thing. Okay. So we talked about that. We talked about involuntary versus voluntary treatment. For the purpose of the exam, let's start about here. In situations where a patient does not have a life-threatening disease or injury, it may be necessary to seek judicial determination of competency or to locate family members who may help to persuade a patient to accept medically indicated treatment. What this is trying to say is, we know it's very easy when it's a life or death situation. What about when it's not a life or death situation? Can I still force treatment on you? No, I can't force treatment on you, and you have to make that decision. So what you do is that you try to rely on other people around that person's life to make that decision for them, to assist them in making decisions. For the purpose of the examination, going to court is rarely the correct answer. Most of the time, 9 times out of 10, if not 9.9 times out of 10, these cases are resolved without going to court and without going to that ethics board that everybody loves to put down as answers. So rarely do you go to court, rarely do you go to an ethics board for an answer. You either have to make the decision, you treat or not treat, and you make that based on the criteria of what the patient has. Okay, we did this. We did that. That's the parts of informed consent. And this is, of course, emergency exception to informed refusal of therapy. So would we treat this patient? What do you think? Is this emergency? Is it life-saving? Can she make that decision? No, so we go ahead and treat her. Was this clear? Everyone understands that. Okay. Let's talk about brain death. This case, I included it in here because I have been told that they love asking brain death stuff on your test. And what's important about brain death for you is that you need to know, first of all, what it is, and second, who is the one that can declare someone brain dead. And that's what this case is all about. A 62-year-old woman with a known history of hypertension is brought to the hospital after allegedly placing her hand on the back of her head, complaining of a terrible headache and collapsing. Paramedics were called and transported her rapidly to the hospital. In the emergency room, she's found to be without spontaneous respirations and movements and lacks any response to painful stimuli. Her pupils are fixed and dilated. Is that a good thing? No. She is intubated and transported to the intensive care unit. She is then admitted under your care as you are a family physician, newly in practice, who is on emergency room admission call for patients without attendings at the hospital. The resident staff approaches you and asks you to declare the patient brain dead so that her organs can be harvested if possible. So, should you declare this patient brain dead? If not yourself, then who? And what is the process for declaring someone brain dead? So let's see if this is in here. Not in there. Okay. Who declares someone brain dead? Yeah, I know a doctor, but what kind of doctor? Usually a neurosurgeon or a neurologist or one of those specialists that they call the intensivist. Those are the 3 individuals that have the ability to declare someone brain dead. The neurologist, neurosurgeon, or the intensivist. Who? Okay, so if not yourself, should you declare her brain dead? You're a family practitioner. No, so the answer is no. If not yourself, then who? Then that's who. I told you who. And what's the process for declaring someone brain dead? There's going to be special tests that you order, and these are in here. Okay, so this is the workup that I want you to memorize to declare someone brain dead, because trust me, it comes out. First thing you do is you might want to do a CT scan. Before that, let me backtrack. You want to make sure if the person is truly brain dead. And there's many things that can mimic brain dead, but actually you're not. And that's what we're trying to rule out. find out if this person has something else which would then make it reversible, and therefore the patient should get better. And what are the things that we're going to do? You're going to do a CT scan looking for what? You're going to look for cerebral hemorrhages. And you find a massive pontine hemorrhage. You do temperature, because a lot of people, when they're hypothermic, they might appear to be this way. So what do we find? The temperature is 99, so we know that hypothermia is not the answer. Toxins, overdoses can also make people look like this. So what do? We do blood work. If everything comes back negative, what do we know? That there was not due to any toxins or any overdose from any medication. And of course, we're going to consult with a physician who is the one responsible for evaluating brain death, and you know what those physicians are. And what does the physician say? The physician gets consulted, and here we go. You consult with a neurologist who finds that there's complete absence of evidence of cerebral or brainstem functioning. The patient is unresponsive. The patient has no pupillary reflexes. The patient has no corneal reflexes. The patient has the doll's eye spontaneous movements or movements in response to painful stimulation. So all of these tests that the neurologist done have come back negative. No spontaneous respiration, so you do a formal apnea test and the patient does not breathe on their own. You then order blood flow studies, and what do you find? There's absence of blood flow to the brain, so that's another thing that indicates brain death. Then, after all of these tests are done, do you need to check it again? Yes, you have to do this again. So you do a second neurological exam, and it's done after the first blood flow study, and about 3 hours after the first exam. And what do you find? Everything is still the same. So what happens? At this point, the patient is declared dead, even though the patient is kept alive by means of artificial support. Now the issue is organ transplantation. And that's something that's a hot topic today. And because of that, there should be something in here. Okay. If the patient is dead, organs can be taken for transplantation if the patient has a valid donor card. Now, all the states have this, and I'm sure in a lot of states in your driver's license, there's a little document, or there's a little thing in there that says whether you are not a blood donor, an organ donor or not. So this is something that you sign, so if something, God forbid, happens to you in an accident, let's say, they look at the card, and they can determine whether you wanted to be an organ donor or not. That's the standard. But what happens is that if the patient is dead but does not have a donor card, who do you need to ask? You need to ask the next of kin, family members, etc. Assuming that the person has a donor card, but the next of kin says no, what happens in most of the cases, if not all of the cases? Is the family denying your wishes? Yes. Is it technically illegal? Yes. But do they do it constantly? Why is that? Nobody wants. Think of the organ donor people. Someone died. You've got their organ donor card. You ask the family, and the family says, I do not want you to take the organs from my family member. Think of the publicity. It would appear in the front page of the New York Times. Organ donor company fights for liver with the family. How does that seem like to you? Terrible. Do you think the organ donor companies, the organizations need that bad publicity? They don't need it. So if the next of kin says, no, I do not want you to take my cousin's organs or my brother's organs, even though you have a valid card, what typically happens? Do they get removed or not removed? Typically they do not get removed. And they do not respect you being the patient's wishes. So that's why it's technically illegal, but it still gets done. Why? Because of the conflict and the bad publicity. So if you notice, there's a push now for the organ donor organizations. I don't know if you've seen the ads. Yes, you're an organ donor, but who have you told? Have you seen those ads? There's a lot of publicity now for that. It's good that you want to be an organ donor, but it doesn't do the organ donor organization any good if you don't tell your family what your wishes are. So you must make sure that you need to educate people. Tell the patients, tell family members, if you want to be an organ donor, tell the family that that's what you want. Because should something happen to you, then they will do everything they possibly can to respect your wishes. So let me review this again. You have an organ donor card and the family says no, they will not remove the organs, because that's something that they like to ask on the test. Is that clear? Okay. Any questions on this? Brain dead and who decides? Remember, you have to know who decides, what test to order, and the issue about organ donors. And that is typically what they like asking on that one section. Okay. Case 3 deals with confidentiality. And as you know, confidentiality is very important. A basic scientist is admitted to the hospital for pneumonia. You are assigned to his personal care. You and your best friend had this man as one of your teachers during medical school. On several occasions, you found his behavior to be bizarre and frequently had alcohol on his breath while teaching. It was a standing class joke that he had a bad alcohol abuse problem. So you and her friend and your alcoholic teacher. While you're having lunch in the cafeteria, your friend notes that she saw your name on the patient's chart and asks, "Well, were we right back then in medical school? How much of a lush is he?" If you don't know the term lush, that means an alcoholic. It's a nice little catchy phrase for an alcoholic. Let's go to the questions. Is your friend involved in the care of your patient? If she is this information relevant? If yes, can it be disclosed in this environment without breaching confidentiality? Your friend is a little snoopy snoop. She wants to know everything about your patient. Ethically, does she have the right to know anything about your patient? Why does she not have the right? Because she's not involved in the care of the patient. That's essential. You're walking down the hall in the hospital. You see a chart of your neighbor, your neighbor's chart. Do you go and you look at it? How many of you look at it? A neighbor you don't like, a neighbor you think is paranoid, a neighbor you want to get rid of so you can, buy his house. Are you tempted to look at it? Will you probably look at it? Yes, you will. But should you look at it? Remember, this is the test. You should not look at it. Why? Because you're not involved in the care. When you talk about confidentiality, they describe it as a circle of confidentiality. And there are certain people involved in the care of the patient that have access to the patient's chart, and therefore whatever they read, whatever they see, whatever they do is also confidential. So if you ask a consultant, you ask me to do a psych consult, I have to look at his chart. And now, am I now in that circle of confidentiality? Yes. If you do a respiratory treatment, the respiratory therapist looks at a chart. Is the respiratory therapist now in that circle of confidentiality? Yes, because anybody who is involved in the care is in that circle of confidentiality. If you're not involved, then you do not have access to anything. And I'm talking about ethical access. If she were to be involved, is it important that this man is an alcoholic? Is that something you need to know medically? What do you think? Are there certain diseases that are more prone to alcoholics? Are there certain infections or certain things that you should know? Definitely. So is this information important? Yes. And if she were involved, or if it were relevant, where should it be disclosed? Whenever you work in the hospital and they give you that 2-week or 1-month orientation, depending how long and torturous they want to make it, what's the first thing they tell you? Don't discuss patients in the elevators. Don't discuss patients in the cafeteria. Don't discuss patients in the hallway. So we're supposed to discuss patients in this circle of, I guess we're supposed to put things over our head and transmit to each other how we talk about these things or anything dealing with the patient. And what's the first thing we do when we're working in the hospital, when we're riding in the elevator? Who are we talking about? We're talking about our patients. When we're having lunch in the dining room, who are we talking about? We're talking about our patients, and better yet, this is definitely true for anybody who's internal medicine. They are such med heads. All they do is think about medicine. You go to a party, and it's people from internal medicine. What do they spend all night talking about? At the party, surrounded by all their drunken psychiatry friends. What do they talk about? This patient with a hypertension, this patient who needed a renal biopsy, that's all they talk about because that's their life. Should you be talking about patients in a party? No. But do we do it all the time? Yes. But is it ethically correct? No. For the purpose of the exam, please, you never talk about patients. You never talk about them in a hospital, in the elevator, in the cafeteria. You need to do it in a place that's considered safe so confidentiality will not be breached. Okay? Okay. Let's talk about DNR. These cases are rather quick. What I'm going to do, I guess you can edit this, right? I'm going to finish the cases that I must finish, and then if you want, I'll just stay. We'll be off tape, and I could answer questions or do whatever, since we would have been finished with the taping. Is that okay?
Yes.
Okay. Let's talk about DNRs and futility of therapy. 64-year-old Hispanic woman with no metastatic ovarian carcinoma is admitted to the hospital. She's very ill but competent. She tells you that she wants everything done. After admitting her to the floor and initiating therapy for her current problem, her records arrive on the floor. On review of the records, it's noted that there has been discussion about DNR status during previous admissions, the most recent of which was 2 weeks ago. She was made DNR 2 hospitalizations ago, briefly, but the DNR order was revoked during that hospitalization. During the last hospitalization, she refused a DNR. Although she does not currently look as though she might code, her disease is very advanced. You believe she might code during this hospitalization. When approached, she reiterates that she wants everything done. When describing pounding on her chest, she stops the physician. She expresses the belief, again, that she wants everything done, and also notes that she knows that once patients are made DNR, nobody pays attention to them anymore. You believe that given this patient's medical condition, cardiopulmonary resuscitation would be a futile therapy. So what are the questions? Excuse me. Is she in advanced stage of ovarian metastatic cancer? Yes. Is there possible impending cardiac arrest? Yes. Is there patient-physician disagreement about DNR status? She wants what? Does she want to be DNR? No. She says, do it all. What does the physician want? DNR. Should palliative care be given as needed? Supportive therapy, sure. What's the issue here? First of all, the ethical consideration, what's the hospital policy about DNR? You should know it for your specific hospital. Every hospital has different DNR orders and policies. Some hospitals, you need to write DNR orders every week. Some hospitals, you need to write DNR orders every month. So you need to be familiar with your hospital's DNR order status. What's important about DNR is that the patient could change their minds as often as they want to. The patient today could say to you, I want to be DNR. And what do? You go to the chart and write it. And the patient tomorrow says, you know what? Don't make me DNR. And what do? You have to go back to the chart and fix that. And the next day the patient says, you know what? Make me DNR. And you have to go back to the chart and change that. And the next day the patient says, don't make me DNR. And you have to go back and you change that. Now, if that were to happen, which typically does not, who gets called? They're going to call the psychiatrist, see if that person can even make the decision. But please remember that the patient has the right to change their mind as frequently as they want to. So you as the physician have to listen to the patient and do what the patients typically want them to have done. But what is the number one reason why patients refuse DNR? And it's possible for you to say that it's a myth, but in a lot of situations it actually does happen. Once you are DNR, what do the patients think? I know what they're going to do if I'm DNR. They're not going to do anything for me. They're going to put me in a room at the end of the hall where no one can even reach that room should I have something happen to me. By the time the nurse reaches me, I'm dead. By the time the doctor reaches to me, forget it, I'm already in heaven or hell, if you believe in that. So you have to make sure that the patients understand that just because you are a DNR, it doesn't mean that we stop treating. And that's what's the most important part of these questions. You need to stress to the patient, you need to educate the patient that DNR doesn't necessarily mean that we stop doing everything and we're going to stick you in a closet and wait for you to die. Because that's what a lot of these patients believe. That is their perception. So it's nothing more than a misperception. Would DNR be futile therapy in this case? What's futile? What's futile? It's useless. Would DNR be useless in this case? What do you think? Does she need? Is she going to die? Is she an end-stage disease? Okay. Now let's talk about futile therapy for a little bit. That I'm going to go off on a tangent here. There's two situations that typically occur in dealing with treatment that's considered futile. One is the patient's or the family's wishes, and the other one is the doctor's wishes. So this is how you have to think of these types of treatment. Let's assume that for disease X, there's treatments from A to Z. Okay? So there's all kinds of treatments that are available for the patient. If you are at treatment Z, meaning there's nothing else for you to do, the doctor is left with nothing else to do. That's it. It's the end of the line. You've tried it all. And the family insists, keep on, try something different. What do you do in that situation? Do you keep on treating or do you stop treating? Keep on or stop? Is there anything else to do? Nothing else to do. You've reached the end of the line, so you stop treatment. And you do not listen to the family. Why? Because there's nothing else to do. What if you're in the early phases of treatment, but you know that if you do treatment C, you do treatment D, you do treatment E, you do treatment F, it's not going to change the status of the patient. You know that. But the family insists that you continue. If that's the situation, then what do you do? Must you continue, or do you tell the patient's family, I'm not going to do anything anymore? You must continue. Why? Because there's other things that you can do. And during all of these other things that you can do, then you try to stress to the family that this is really useless. But until they change their mind, you have to keep going. Does that make sense? Okay. So again, you have to explore the patient's reason for not wanting, and the patient, of course, is afraid of abandonment by the medical and nursing staff, and you have to assure her that this will not occur. 3 days later, the patient has a cardiac arrest. You're obliged to do a full code on this patient, and CPR is done in the absence of a DNR order because you have to do it. As long as there's no DNR, you have to do a code. Okay, this is the one that's the hot one. Everybody loves this one. This is the Jehovah's Witness refusal of blood for adults, for children, and this is one that's very popular. 54-year-old man comes to the office for his first visit since he moved to this area. He has a known history of hypertension and bleeding esophageal varices. Physical exam reveals no acute problems. During conversation, he says, "Doctor, I know I have problems that you might usually treat with blood, but you can't with me. I'm a practicing Jehovah's Witness. If you give me blood, it's a horrible offense to Jehovah's law and to me. Even if it means that I might die someday, you cannot give me blood." Does this person sound rational to you? Does this person have the capacity to make that decision? Yes. So if he has the capacity, do we have to honor his decision? Yes. So is this a competent or incompetent refusal of potential life-saving therapy? Is it competent or incompetent? Competent. So is he legally competent? Yes. I mean, he's of age. He's not a minor. Is he clinically competent? Is he making rational decisions? Yes. Does the patient understand the implications of his request? Yes, he tells you, if I don't get this treatment, I know I'm going to die, and I'm okay with that. And can the physician meet the patient's demands? This is where you need to understand one thing. Just because a patient tells you, I don't want treatment, if you feel uncomfortable for that, then you don't have to do what the patient says. But you must provide someone else that can treat the patient. Does that make sense? The patient tells you, "Doctor, I don't want blood. I understand that if I don't get blood, I'm going to die." You cannot tell the patient, "Okay, you know what? I have a hard time doing that, so goodbye. Go to some other hospital," and walk out of the room. That is not the option. The option is you say to the patient, I cannot do that. I have a hard time doing that, but I will find someone for you who does not have a problem granting your wishes. That's acceptable. Same thing as abortions. If a patient comes in requesting an abortion and you don't perform abortions, must you do it? Of course not. You have the right to refuse. Same thing applies here. Just because the patient is requesting this doesn't mean that you are the one that has to do it. Okay, so let's talk about other issues here. The Jehovah's Witness patient are the ones who have the blood questions all the time. They're going to trick you in the following way. This patient, then the question will be, what is your next step in the management of this patient? And choice A could say, transfuse. Choice B could say, don't transfuse. Choice C could say, go to court. Choice D could say, go to the ethics board. Choice E could say, discuss other options. And what do you think is the best answer for that? Discuss other options. This patient is not saying, "Doc, go ahead and kill me." What this patient is saying, I will accept other treatments, but not blood. They will not accept anything that is blood or a blood-borne product. They will accept IV, they will accept fluids, they will accept plasma enhancers, anything, but not anything containing blood. So does this mean that you just allow the patient to die, or does it mean that you still do other things available? And that is always a better answer. So be careful, because those types of answers, what do you think they put in the last choice? Discuss other options. Because you saw the don't treat one, you go for it, you think that's it, and you move on to the next question. Be careful to read every single choice. Let's talk about adults. And I'm going to give you various scenarios. Scenario number 1. An adult is brought into the emergency room, unconscious, wearing a shirt that says, "I'm a Jehovah's Witness, God loves me." He needs blood, he needs treatment. What is your answer for this patient? Treat or don't treat? He's unconscious, emergency. If you don't treat him, he's going to die. You got to pump him up with blood. If you don't do that, he's going to die. But he's wearing a shirt that says, "I'm a Jehovah's Witness, God loves me." What do we do? Treat or not treat? Think of the exceptions to informed consent. Is emergency one of them? Is this an emergency? Do we treat him? Yes. Forget the t-shirt. What if he borrowed it from someone? All right? And you're going to let a patient die because he's wearing someone else's T-shirt. Do you imagine the legal complications of that? So our job is to save lives and not kill people if we can help it. So we have to save his life. Scenario number 2. Patient gets brought into the emergency room, still unconscious, still wearing the Jehovah's Witness T-shirt. I'm a Jehovah's Witness. God loves me. But this time he comes in with a wife screaming beside him, I'm his wife. Don't treat him. He's a Jehovah's Witness. Do we treat or not treat? How many of you say treat? How many of you say don't treat? Treat is the answer. What if that woman's not his wife? What if they were never even married? How do we know for sure? What is it that we're dealing with in the balance here? We're dealing with someone's life. Why do we listen to next of kin? Why do we listen to spouses when they say, disconnect my family member from the respirator? Do you know why? Because are you going to live if you're on the respirator? Assuming you're brain dead and you're being kept alive by artificial means, who cares if you disconnect the respirator? You're going to die. There's no good outcome of that. But if you refuse treatment for this man, are there any good outcomes? The only outcome is his death. And her possible. What if she's meant to inherit a whole bunch of money? Not even his wife. And you allow him to die because you took her word on it. You know what's going to happen? Mr. Attorney is going to be making you a visit very, very quickly. So that's not what you do. You treat because it's emergency. Who's the patient? The woman who claims she's his wife, or the one lying on the stretcher? The one on the stretcher. Scenario number 3. Unconscious man needs the transfusion. Wife screaming behind him, I'm his wife. She pulls out a document with his expressed wishes, a legal document, notarized, signed by the man. Now what do? Now we don't do it. Why? Because this is like a living will. You have to respect it. So now we know what he wanted in that situation, and who has the ultimate responsibility of making sure we as physicians comply with other patients' wishes. You have to bring the document to us. If I don't have the document, how do I know what you have? And now we allow that patient. We do not give the blood. Do we still do other things? Of course. That makes sense for adults with Jehovah's Witness? Let's talk about children now. For children, anyone who's under the age of 18, minors I should say, not children, the courts basically are very protective of them. And the courts will not allow parents to make decisions that could ultimately affect their child's life. So in children, you have to think of several scenarios. Number 1, ask yourself, whatever happened to this kid, if I do not treat, will the kid die? Or limb saving. It's also limb saving. You've got an arm hanging by a thread. The family says, oh, don't cut the arm, don't save the arm, because we're Jehovah's Witnesses, and Jehovah says if you have that arm, you're going to go to hell. What do? Do you listen to the parent? Of course not. So whenever you have a minor, and it's issues of death, imminent death, or limb saving, I should say, we don't listen to the parents. And what's your ultimate answer? Don't put go to court. Don't put second opinion. Don't put go to the ethics board. You put down, you treat, you operate, you do whatever is necessary to make that kid live. Is that clear? Let's take it a step further. Death is not imminent, but probable. You will not die now, but you probably will die in the near future without the treatment. Do we need parental consent? Yes. Parents say no. If the parents say no, what typically happens is the following. The child can become custody of the court. So basically the child gets taken out of the control of the parents, and who do you think grants permission for the treatment? Then the courts grant permission for the treatment. Scenario number 3. Death is not imminent. Death is not probable. Nothing is going to happen to you whether you refuse it or not. Must you get parental consent? Yes. If the parents say no, what do? You shut your mouth and you don't do it. Now it gets ugly. What if one parent says yes and one parent says no for this treatment? All you need is one to say yes, and you go ahead and treat. But you know deep down that if it gets really ugly, you know where it's going to go? It's going to go to court. But all they care about for the test is one yes, and one yes means treatment occurs. What if 15-year-old wants treatment, parent says no to treatment? Not life-saving, not anything. Do we treat or not treat? Parent says no, kid says yes. Treat 15. Treatment whatever, for something trivial. Do we treat or not treat? Not treat. Why? Because who's the one that's giving us the consent? The parent or the minor? The parent. So we listen to the parent all of the time. So is this clear? Okay.